welcome to the 2020 Brain and Transcranial Photobiomodulation Virtual Summit. I'm your host, Dr. Joe Doduro, and my guest is Dr. Harold Kraft. He graduated magna cum laude with an undergraduate degree in bioengineering from the University of Pennsylvania. He earned his MD in 1981 from Georgetown University Medical School and served as a resident and as chief resident in anesthesiology at Georgetown University Hospital. He spent 20 years in anesthesia and 20 years in software development, and he's treated 20,000 pain patients with laser. He's one of the first pain anesthesiologists to treat pain patients with just laser, no drugs, no epidurals. So he's an editor of the Psychology and Behavioral Science International Journal, a member of the American Society for Lasers in Medicine and Surgery. And this guy's got the real deal. I'm excited to hear his presentation and what he has to teach us and learn us something here. Thanks, Doc. Oh, I have to take my glasses off. Those are just my blue blockers. Thanks, Doc.
You're welcome. And Joe, thanks for inviting me, and welcome to everybody. Thanks for listening.
That's great. Now, how does you are in the year, I'm an 86 grad, and so right coming out of the 70s, there was a high amount of dogma in the allopathic world. Yet, you're embracing a completely drug-free, practice at this point. Tell me how that happened. How did you get into lasers, and how did you get into using it on the brain, if you don't mind?
Sure. So I guess I spent 20 years on the East Coast, which is sort of the more traditional coast, if you will, doing very traditional general anesthesia, regional anesthesia, knocking people out, waking them up, giving them epidurals for pain, and I had a back pain practice, so I did epidural steroids. And being an anesthesiologist is easy because patients, A, don't talk to you much, and B, when they do, you just give them some drugs. It was very traditional. And then I retired completely. I actually had some overlapping careers. I have a second career in computers and entrepreneurship, started and built several companies. And then towards the end of that stint, the sale of none of those were in medicine. The sale of my most recent software company brought me out to California, which is the more interesting coast. And while I was out here, actually my wife told me that her dog had stopped walking. She was still back east. And the dog had failed doggy acupuncture, doggy chiro, doggy PT, doggy supplements, doggy everything.
Doggy whisperer, doggy whisperer.
Yeah, the dog gets treated very well in life. So she said, the vet said, I'm going to laser. So she asked me what I thought, and I said, look, I've never heard of it. It couldn't possibly work. But it's a dog. So she ignored me. She went, the dog started walking again. I saw with my own eyes. It's a pug. Dog started walking after 2 or 3 laser treatments, maybe 6. I wasn't there. The dog truly went from not walking, from arthritis, hip arthritis, to walking. And I still thought, you know what, this is a fluke, because I'm a doctor and I know all about the body. Number one, if light could enter the body, I would have seen it in the operating room, right? You look inside people's innards, light never goes through the skin. And number two, if light had a physiologic effect, I would know about it, because I know all about that stuff. So I thought, this is impossible. But I had because I'm on the West Coast, my mind was slightly open. So I read more about it. It seemed like it had some good basic science physiology behind it. So I thought I would give it a try, but I had no faith in it. So I was patient 0. I happened to have hip bursitis at that very moment, bad enough that I myself was going to go see an orthopod, which for a doctor has to be very bad. I went and I happened to get the laser, so I lasered myself, and it didn't work. Lo and behold, of course, I had so little faith in the laser that I sublet a medical office with a month-to-month lease, so I can opt out quickly. Laser did not work. I went 4-6 treatments, still didn't work. And then I thought, you know what? This is silly. I'm used to taking people close to the edge of death, taking them with drugs that could kill them. So I upped and upped and upped the dose to 5x, and magically my hip bursitis began to disappear. At first I thought it was placebo, but I have to tell you, it's been gone 5 years now. I've never had a day of bursitis since. And so I thought, hey, maybe this laser has some benefit.
I like it. I like it. I like it. And so you went from the butt head to the head. So tell how that go. You went from your hip to your head, you know?
Yeah. So, I had the laser practice really began to take off because by that time, I'm in Los Angeles, which is, I'm in actually two fairly advanced or liberal cities compared to the East Coast, Santa Monica and Manhattan Beach, 2 parts of LA. Everybody was open to new ideas, definitely not into opiates. And so the practice grew, but I was looking for new ideas, new ways, new things to do. And I discovered the article by Moyes and Henderson about the brain. And I actually knew nothing about PTSD, but I thought this sounds pretty powerful. And so I started to treat some patients, one patient in particular with PTSD, and it had an unbelievable, amazing effect. Again, the physiology makes sense. And certainly it's just like a lot of chronic pain conditions, PTSD is a condition for which there are very, very few good options. And so, sort of once I tried it on one patient and saw this unbelievable results, I realized what it could do.
Now you were doing a lot of the back pain and the pain aspect. So you were treating the physical, you were treating the body with laser all the time. You had a bunch of them probably at a busy clinic, and you were taking care of it. You were changing the physiology on their pain processing, right?
Yes.
And then when you turned it around and put it on the head, how did you find the somatic things change? Did you kind of look at the body a little bit different by looking at the head? I mean, how did that change for you, Paul?
So actually, I was surprised because most of my patients, even if they had pain, did not report, the PTSD patients, even if they got better, did not report voluntarily significant changes in their somatic pain. It could be that I really wasn't focused on that, or it could be that because I didn't treat their somatic pain, that the connection between PTSD and pain is maybe a little different than we're thinking.
Oh. Just wondering, because it seems to work the other way. If you treat their back pain and their depression gets better. So
absolutely, that I agree with. I've seen that all the time. I just didn't see it from the depression side to the somatic pain side.
Yeah, so I wondered if the head was connected to anything else. But hey, you're doing great. Let's want to take a look at your slides?
Absolutely.
So this is going to be the effects of laser transcranial photobiomodulation therapy in the treatment of PTSD in a veteran. A clinical study to investigate a novel, rapid, high-dose approach. Okay, let's go. Beautiful stadium. You were telling me that's a mock-up of the new stadium that's going to have the Rams and the Chargers, right?
Exactly, and about 1/3 the number of people. So, Joe, thanks for that introduction. Okay, so we're just going to talk fairly quickly about past, present, and future. We'll start with my past. I have 3 backgrounds: medicine, engineering, and software. So I spent 20 years on the East Coast in DC as an anesthesiologist, knocking people out, did epidural steroids for back pain. I spent 20 years doing scalable databases and software as an entrepreneur. And then for the past 5 years, I've been in Los Angeles. I have a pain clinic, Laser MD Pain Relief. It's my only hammer, which I'll explain in a minute. And in terms of somebody who treats only sort of high degree pain with only laser, I think I'm probably the leader of the 20,000 treatments of only laser. Sort of 20 years, and 20,000 treatments. And there's a lot of overlap there, so that's why it does not look like I'm 100 years old. Okay, so a lot of my approach to laser comes from my 20 years as an anesthesiologist. As an anesthesiologist, more drug is better. Whatever the question is, 99% of the time the answer is more propofol. Propofol is Diprovan, the drug that Michael Jackson was fond of. It's a wonder drug. You can substitute your own drugs for that, but generally speaking, when you're an anesthesiologist, almost all problems can be solved by more propofol. Any drug as an anesthesiologist is better with more of it as long as you understand the side effects, the pharmacology, the physiology, and the mechanism of action. So that's sort of my background, is more is better. My core experience is 20,000 laser pain treatments. I have a pain clinic. Basically, a third of my patients have already failed epidural steroids, radiofrequency ablation, surgery. A third of my patients are sort of your typical pain management patients with high degree of pain. And a third of my patients are low to moderate pain that, whether they should see anybody or not is debatable, but they came to see me. I prescribe 0 drugs, no narcotics, no gabapentin, nothing. Like in 5 years, I've probably given maybe 10 steroid dose packs, and that's it. I do not use any adjunctive therapy. I don't lay hands on. I don't touch the patient. And if I had my way, I wouldn't even talk to the patients. I'm not a psychiatrist. Basically, you come, you have pain, you get lasered. If pain goes away, it was from the laser. If your pain doesn't go away, it was a laser failure. I keep very accurate statistics. And also because I have one hammer only, then I've got to optimize that laser treatment, absolutely optimize it for each patient because I don't have any other options. So overall, I won't cover the patient 0 anecdote, which was me, because you may have heard that in the intro comments. But overall, what I found is that most patients tolerate high and very high doses without side effects. They almost never melt. And by that, I mean, if you read some of the basic science literature and a lot of the comments by some of the other lecturers in this series, you would come away believing that if you give too much laser, the patient or the brat or whomever will melt. They'll have these serious side effects. Everything will go downhill. They won't get any benefit. And after you've given 20,000 treatments, more than half of which are way over what you would be considered a therapeutic dose, those patients do not melt. They love it. It's basically like giving more propofol to the patient. More is better. Okay. There are some patients.
Now let's just make a point here. Let's make a point.
Yes.
These are, you're doing these laser treatments in the musculoskeletal system, correct?
For the most part, yes. The same applies, which I'm going to get to later, to the brain.
I know you get there, but let's just say,
but yes,
something might melt, though. We don't know all that stuff. You put it on someone's buttocks, you could probably turn it up pretty high. I'm with you.
Yeah. So for 20,000 treatments are musculoskeletal. I've had a few sort of intestinal, but generally by and large, musculoskeletal. Gotcha. There are some patients who for sure have had their good effects negated by the bad effects from too high of a dose, but it's sort of 90% of patients would like more and 10% would like less. And I give a ton. I'm often giving as much as, you can sort of do the math here, but it looks like 200 joules per centimeter squared per treatment. And sometimes I repeat that treatment 10, 20, 30, 100 times in the course of a year. I mean, these people are getting a significant quantity of total laser. What I have discovered is one interesting thing that explains a lot of the variation. Some people like low dose of laser, some people medium, some people high, is that there's absolutely a genetic dose dependency, which is based on maternal haplotypes. So I have a group of patients in whom I've treated multiple family members, and if one member is a super duper responder, the other maternal family members are also very high responders. the sort of, for me, the one big scientific, basic science realization was reading two papers on absorption, which showed two huge absorption losses of 80 to 90% per centimeter, and those reinforced what I've been seeing clinically. And I will add, Joe, that if you talk to most of the manufacturers, certainly some of the leading manufacturers, they will perhaps on the phone and under their breath admit this 80 to 90% per centimeter absorption, but they don't dose that way. The one exception is Aspen Lasers. They actually are one of the only manufacturers I found that encourages a reasonable dose, the dose that I'm using.
May I remember I'm the kid in the class that always raises his hand. So I was wondering a couple things here. One, when we talk about absorption, you know what I mean? We can, and I think that's a good point that you made, and we need to know how much is coming out of the end of the device regardless, right? And that, so we can make quantifiable justification, you know, we have to use our minds after that. But remember, absorption is not a bad thing. So even though you're looking for a direct response, as we like to say, and you want to get that laser to that spot, that direct response, but the absorption is the indirect response. What if you think about it that way? That it's not negative, it's just, darn it, it's not going to the point that I want to go to, which would be the direct effect. How do you think about that?
Right, so that's absolutely on point. Basically, all laser gets absorbed. It can't come out, well, unless you're lasering the hand, it doesn't come out the other end. Just let's assume you're lasering a muscle or a head, a bicep or a head, all laser gets absorbed. So the question is, does it get absorbed in the right place or before it gets to the target?
Correct.
Good point.
Thank you.
All right, so let's go on. My favorite absorption paper was Tedford and Anders. The reason I like this paper is it had this phenomenal rainbow picture. You can never go wrong with rainbows. They did a study in cadaveric human brain, showed about 90% absorption per centimeter. If you don't want to get into the nitty-gritty details, you look at these pretty pictures, and what you can see on the right is, say, going from, you can pick something on the right. It's at the very bottom blue, it's like 1.9 e to the minus 0.5. And then if you just look kind of until you see up 1.77 e to the minus 0.4, that's a tenfold difference. And if you look anywhere along here, you'll see that to go that same blue from dark blue to really light blue takes about 10 centimeters. 10 millimeters. So 1 centimeter equals about 90% absorption in their scenario. You can get a lot more refined. You can see some of the divergence. But the bottom line is that they showed 90% absorption in human brain.
And these are different probes, are different wavelengths. Was that what you're saying? The different probes, is that what they're measuring?
So yeah, I think the probes might either be different powers or slightly different wavelengths. I don't recall off the top of my head.
But anyway, it's going to be dispersed. We've seen all the graphs, but you have a lovely rainbow.
Yeah, don't thank me, thank them. This is straight out of their paper. The other paper, this actually came out first, was from Henderson and Morris. They showed roughly 70%-ish absorption per centimeter. They use fresh lamb brain. They also quote 2 millimeters of skin, which is nothing. 60 to 91% absorption. They showed a huge, huge difference between, I think, pulsed and continuous and 800 and 900 nanometers or 800 and 1,000. But the bottom line is that there is a lot of absorption before you hit your target going on. So takeaway message, small target dose equals a big skin dose. So just in terms of round numbers, if you're looking for, if you start with 1,000 joules at the skin, you would end up with 1 to 10 joules at 3 centimeters into the brain or 3 centimeters into the muscle.
Mhm.
If you are trying to go 4 centimeters, 4 centimeters is not that far. Then you need around 5,000 joules at the noggin, at the skin, to get roughly 1 joule at your brain target. You need powerful machines, in my opinion. I happen to use, these are the machines I use. I use ones from Aspen Lasers, which I really like. LightCure, sort of one of the original big players, but please note that their machine has divergence. It is not a straight shot, so if you're aiming for the prefrontal, I'm jumping ahead, but if you're aiming for the prefrontal cortex, it always makes me nervous because of their divergence. CurePoint and DiaWave. All right, that takes care of my past. That's my background, mostly a lot of treating 20,000 treatments of pain. Let's fast forward to how I got into the brain, so to speak.
One more thing here. So
yes,
you're kind of the guy who would know precisely how much 3 centimeters or 4 centimeters is, because you had to take a needle and put it in X amount of distance. So you're not guessing. You know. Am I correct?
Yes, that is correct. I mean, I think all the time about when I'm lasering somebody's back, I think about the distance to that nerve root. To where the target is.
Right. Okay. Go ahead. Denver study.
So, but in terms of the brain, which is really what we're here to talk about, people are talking about the prefrontal cortex, the frontal cortex, all these cortexes, and they are many centimeters further away than a lot of people realize. So, of course, my favorite article, many people's awakening, was this article from Henderson and Morris about treating traumatic brain injury using near-infrared laser. And this article really opened my eyes to the fact that the brain was susceptible to laser treatments. And I did something which probably many people haven't done, which I'm going to show in a second. I looked at that article as an engineer. But the summary of that article is that I call my patients and my staff are not smart enough for all those letters of tPBMT, so I just call it transcranial laser therapy. It's much simpler for us to understand, but it's the same thing. It's painless, it's non-invasive, it's class 4 laser, and you can see me here as the mock-up patient getting in this case it's actually a LightCure laser to my head. And the Denver study from Morris and Henderson used lasered roughly regions A and B, the forehead and the temporal area. And I've summarized, they might not agree with this, but my summary of their protocol is they use 15 treatments, a constant dose of between 5 and 9,000 joules per treatment. The treatment series lasts about 60 days. They either gave patients 10 treatments or 20, and the total dose on average, if you lump all their patients together, was around 114,000 joules, averaging about 7,000 joules per patient.
Right.
So that was their protocol, and they had some phenomenal results. I mean, these results, these are the graphs, these are from me, not from them. I do much better with graphs because of my engineering background. When I popped these graphs into Excel, it was just astounding that a single therapy could cause so much change in a PTSD, TBI condition that seemed to be, there was nothing else that touched this. And they're talking about depression that improved by 50, 60, 70%, suicidal thoughts virtually disappearing from half their patients to none, patients with sleep disturbance, and we're not talking about people who have an occasional bad dream. We're talking about suicidal nightmares, gone from 100% of 10 to 0% of 10. A lot of these are qualitative measures, but they are, even if you're making half of this up, these are phenomenal results. So when I saw these graphs, I thought there must be something here. And then I did something, and again, this is my Excel, not theirs. Because I'm a propofol, Diprivan dose response guy, spent 20 years thinking about drugs, I wanted to see if there was any kind of dose response. So I did something, and maybe I made this chart to my liking, not to science. The one thing they reported on was the response to the two measures, or the one measure of depression, sorry, the Beck Depression Index. They quantitatively reported those numbers before and after, and then I plotted their change in depression index versus the total treatment. And other than one outlier, which I threw out, you see a very nice approximate dose response curve, which made me feel good. The more laser you give, the more effect. So I thought, hey, this actually looks pretty interesting.
Like it.
I could get into this. Here's a drug. And I'm sorry, Joe?
I like it.
So again, this is my view of their work. They may or may not agree, but it made me feel a lot better about laser being a drug or therapy. So I came up with my own protocol, and my own protocol was more is better. I'm back giving anesthesia and drugs, and I want to knock them out. So I came up with a protocol that used roughly a 3 times higher dose than Denver, at least twice as fast as Denver, twice the coverage of the frontal lobe, and a deeper penetration of the frontal lobe. And then I started treating vets and mostly female victims of sexual trauma, and sometimes people who had both conditions. I've treated 12 patients. They all had a PTSD PCL score of at least 50. It's a self-funded study. There are no conflicts. Mostly I use the 60-watt Aspen 980 nanometer laser, and we use real-time temperature monitoring. On the right, you can see, compared with Denver, we use a much bigger forehead. We use a much bigger sort of temporal area. We're just much bigger on everything. That's just our choice. It also requires a lot less precision if you just do everything. Here's sort of a little bit more about our protocol. On the left is Manhattan Beach mine. On the right is Denver's. So the Denver protocol sort of typically ends at or for most patients, is 9,000 joules per treatment. That's actually our starting dose, and we go up to either 25,000 or for patients with bigger heads, 36,000 joules. I will say in that range, I did not have any side effects. I have had one other patient with two other patients with head side effects, which I don't think were dose related, but I can't rule it out. But they were not part of this series. Actually, 3 other patients, now that I think about it. If you want, we can talk about those later. Total length of my series, I did a lot of patients at 15 days with every single day treatment.
Okay.
And almost everybody got treated within 30 days, occasionally 45, versus Denver 60 days. So these patients have a job to do, and that job is getting their head lasered. I think it goes unspoken. I think this is also true of Denver, but I make everybody shave their heads so they have hair just like mine, male, female, at least any place we're lasering has got to be pretty naked. Total dose for us was 300 to 450,000 joules. Denver dose averaged 114,000 joules. So we're definitely blasting compared to Denver. We measured the PTSD score using the PCL, where greater than 33 is clinical, roughly 33 or over is clinical PTSD. We used the Beck Depression Index, which obviously measures depression, the Quick Index of Depression, QIDS. We measure these every few weeks, not just beginning and end. An SBQ survey, which is very brief, which measures suicide, and a nightmare survey called the DDNSI, which obviously measures severe nightmares, the kind that hopefully you and I will never have. Links to a couple of videos if you want to see what we look like. And here's just a snapshot. We have a real-time thermal camera. It's measuring, I think, about 300, 400 points on the head constantly. We have a couple fans going. We have the laser headpiece, and we have a veteran with eye protection. A lot of the patients, by the way, describe the feeling of being lasered the way we do it as getting a head massage, or actually a brain massage, which I can't relate to, but at least a quarter to a half of my patients have described that spontaneously. So this is patient number one. This was, obviously I like this because it really convinced me that something was going on. This patient had a PTSD score of 63 in green that fell quickly on our first measurement to 24, and then over the course of about 3 weeks to 5, almost 0, really. And it doesn't show on here, it shows 9 months, but 2 years later, more than 2 years, she is still measuring normal on the PCL scale.
Gotcha.
She measured both depression scales, but in this one it's the BDI, the Beck Depression Index. She went from 35, which I think is moderate or moderately severely depressed, down to normal. What's interesting to me is most of my patients, their symptomatic report lags. They'll often report that they don't feel as many changes as the numbers are showing. By the way, I think the Denver people might give, they might not agree with this, might give some either gentle encouragement, or they encourage you to go out and sort of relax and think and breathe the Denver mountain air. I'm an anesthesiologist, so I try not talking to anybody. I tell my patients, go home, go to bed, come back in the morning. I ask them for side effects, and otherwise you're on your own. And I tell them right up front at the very beginning, I'm not here to talk about your depression. You have issues, that is not what I'm here for. I'm here to laser. So I think this, occasionally I get suckered into hearing about some problems, but it's just out of my field, so they don't get much feedback from me.
I like it. And I think I like the graph because you're putting there, I looked at there's the kilojoule dose, and you're putting it underneath there, and it's sort of seeing this, a dose and then a dose and then a dose and then a dose. And so I think that's a great way to represent the treatment. But I have a question because of the previous slide. You were telling me, I think you were telling me that you're increasing the dose as you go with the relative treatment. Am I mistaken?
Yes.
But this is number one.
Yeah, absolutely right.
You were just getting going.
Yeah, exactly. It was my first patient, so I increased from a little baby dose the first time to the second treatment. And this patient actually reported some very minor, what I consider to be possible side effects. And so I scaled back, and it was my first patient, so I thought, you know what, I don't know really what I'm doing here. So I'm going to not increase.
This is your brain. This is your brain. This is your brain on laser.
Yeah, so she reported burning at the top of her head where I had not lasered. I discounted this because she also said, I've had that before you ever touched me. But I couldn't, in good faith, increase the dose beyond that. Right? It's the brain. So I'm very respectful of people's brains. All right. So a recent patient of mine, this is a vet, like a 35-year-old guy, unemployed, seriously depressed. I apologize because I don't have a graph, so we'll have to read the numbers. So, you can see he's got a PCL score of 66. He's definitely has PTSD. He's severely depressed. He's got suicidal thoughts. He's got very profound nightmares. This guy is a hurting turkey. We start lasering him first with 12,000 joules, 16, 20, 24, 26. He had a bigger head. So we ended up going to 36,000 joules. And we were a little delayed on his first measurement on day 21 after 9 treatments. We measured his scores again. Everything was down by half to 60%.
Right.
He didn't feel that good, but the numbers were that good. Couple treatments a week later, he's down by 2/3. He's down in, relatively speaking, the green zone. His PCL score is now 14. His depression scores are 3. That's 3 and 17. That's fairly normal. His suicidal thoughts have gone down, and his nightmares have gone down. And in my experience, one of the very first things that people will report if they're going to be a responder is they will report subjectively that their nightmares have gone often after 3 or 4 of these high-dose treatments.
And they're sleeping better overall. Won't they recommend that they're sleeping better? They just say, I'm sleeping better. Right?
Yeah, they definitely sleep better. Although some patients are now end up having dreams, and I've had some patients who haven't had a normal dream in a year or sometimes a decade, and they're flummoxed. They don't understand what a dream is. I've had one woman who had severe sexual trauma, and since she was a child, and had in the past 40 years had never had what she believed to be a normal dream, and she didn't actually have words for it. She called it a positive nightmare. And I said, what is that? And she explained it. And I've had 2 patients who said, use those words, positive nightmare.
Because so the only representation is night terror, right?
Yeah, night terror, right. So
time.
Yes, this patient in front of us here is my favorite patient because within about a month of this, he went out, got a job as like an assistant manager at Costco, and it changed his life. He never took one of my surveys again. Unfortunately, he was too busy with his job and his wife, but he had great results. So what does the future hold? I'd like to address a couple areas. One is I can't control the science or what everybody is investigating, but I will tell you as an anesthesiologist, there's the theory of science, which should guide what happens. You find a receptor and you develop a treatment that either stimulates or blocks that receptor. But there's the practice. And in medicine, especially in my experience in anesthesia, is oftentimes somebody does something, they do laser, they do a drug, they do something to some patient, they observe something that's like, oh, wow. And then later on, the theories are developed to explain that. So I tend to sort of not get too hung up or take with many grains of salt some of the basic science that is being discovered. For instance, which frequency is better, pulsed or not pulsed, which regions of the brain are involved. I tend to think of as we really don't know as much as we think we do. I like to use the example of the Milky Way. The Milky Way has about 80 billion stars, roughly. Some people think we have 80 billion neurons and 80 billion helper cells, the astrocytes and the glial cells as well, 160 billion total, which may play a role. And, if you're really smart, you know all 52 of Brodmann's areas, but even 52 Brodmann's areas gives 1.6 billion neurons per region on average. And that's just a lot of neurons to group together. I really don't think that if we're talking about the prefrontal cortex, that we really know much about what's going on. That's just my view. And I don't know all 52 Brodmann's areas, but I do know a couple things, which I'm going to get to. We talk about the frontal lobe, know some things, and people can dive into this. Maybe they can, using a knife, cut closer than 52 areas. Maybe they can get into 200 areas or 400 areas. You're still talking about hundreds of millions of neurons. And each of those neurons is almost independent. We're grouping them together because, frankly, we don't use all our brain power. We're not smart enough to. What I would like to talk about is that most of the cortex is more than 2 centimeters from the skin. So here's an MRI sliced right down the middle of somebody's brain. And as you probably know, if you slice right down the middle, you sort of get the half of the brain that has cortex. I measured it at the bottom. You can see I've measured, it's about an average brain from stem to stern is about 20 centimeters. And if you look at the ventromedial prefrontal cortex, which a lot of people think is important for PTSD, executive function, TBI, from the skin to the deepest reaches of the ventromedial prefrontal cortex is about 6 centimeters. And the brain is invaginated or involuted, and there is cortex. More than half of the cortex is more than 2 centimeters away. So people using what I consider to be light doses are only truly touching the surface, maybe 10% of the cortical cells that they could touch. So I have a hard, I know I don't want to discount something that's not my baby. I'm high dose. I have a hard time sometimes believing that low doses can reach far enough to do their work, but I also didn't believe laser would work before I tried it. So I'm willing to believe anything, but sometimes at some point the science has to match the results. So just, the other interesting thing is at my doses, why isn't the first few centimeters getting burned or melted and having deleterious effects if I'm using that high of a dose? I can't explain that, except I think that we only know 10% or 20% of what we'll eventually know with photobiomodulation. My sort of theory is that there are 4 requirements for a therapeutic effect. Number 1 is the right dose at the right target. Obviously, I think there's high doses are important because the absorption of pre-target areas is huge. You need the right color, whether that's 800, 900, 1,000 nanometers, some other frequency, I don't know. People talk about what is important for cytochrome C. Yes, that's important, but losing 90% or 99% of the power and absorption in the skull probably more than makes up for using a slightly incorrect frequency or suboptimal frequency. So you have to sort of balance the two. A lot of studies are done with cells directly exposed. Sort of if you're measuring cytochrome C in a blender, you've put them in a blender and you got cytochrome C. Sure, you can get that laser right to where you want it. That's very different from 6 centimeters into the prefrontal cortex. The right target, and the brain is actually relatively easy because if you stick to the 4 regions or the 52 Brodmann's areas, you can't go too wrong. Number 1. Number 2, the laser disperses, it diverges. So if you're aiming it right at your forehead, it goes everywhere. It goes a lot of places you don't want it to. That's both good and bad. But I think in terms of those 3, the right doses, the right color, and the right target, we're only at 10-20% of what we'll eventually know. And on the right dosing schedule, pulsed versus continuous wave, daily versus weekly versus monthly versus continuous. You wear these continuous devices. I think we have no clue. We know 1% of what we'll eventually know. I don't think my dose is right. I can almost guarantee my dose is not the optimal dose, because how could it be? We're shooting in the dark, right? My dose seemed to work pretty fast. I don't think it's the best dose. So I don't get too hung up on doses. Use whatever dose you're comfortable with. I'm sort of bent towards an anesthesiologist. I think 2 minutes is too long to wait. So 2 days is way too long. The future for us involves higher dosing, better testing, synergy with other non-photobiomodulation modalities, and again, daily treatments for me, faster outcomes. That's just the way I'm groomed. And mobile units to anything to bring the laser to the patient rather than having the patient to come into our clinic.
We'll talk about that. I like it. Dr. Kraft. Good. So can you go to, I'm still a little bit, I don't know what is your parameter when you're blasting? Are you doing constant continuous wave or are you pulsing it?
Yeah, I should have mentioned that. We only do continuous wave, whether it's pain or brain. I'm always intrigued when I read that people see lower rise in heat, for instance, with pulsed versus continuous wave. And obviously it's got to be joule to joule. So 100 joules produces a lower temperature rise, or it might produce a greater effect, or it might produce greater change in greater absorption of the cytochrome C oxidase. I'm always highly intrigued by that. But at the end of the day, the choice between going 30 miles an hour and 60 miles an hour, all the way through 60, and I may be wrong. It may be.
You can't help it.
Now,
Can't help it.
yeah.
You trained that way. You put.
Right. Now,
You're doing. Let's think about this. Think about this for 1 second. I'm going to say what it's. I was just thinking. You're a classically trained medical doctor, right? And you're worse, you're an anesthesiologist, which they don't really even know how anesthesia works. But yeah, you guys
right.
are just hell bent and just keep going and doing it. So you've got the courage of a fighter pilot. That's great. That's what you want. You want somebody that's going to be react. You know what? I have to have this surgery. We really don't know how it works, but I'm going to do it, and I'm going to take responsibility. I'm going to do it. So you got big ones, and that's what you do. So when you're going to have a laser, you're not going to go, well, let's just tap away at this. No, you're going to go big time, and you help a lot of people. You're doing a great job with these people. And if you were going to do damage, you're the perfect guy to do it because you almost kill people every day anyway. So you're good at it.
Exactly. I think you've summarized my approach to patients perfectly.
But I also said that you are like a chiropractor, because that's what a chiropractor does. It's not a talk cure, and the greatest chiropractor that has ever really been around, and one of the greatest, he used to shave the patient's heads so that he could get a better contact on the occiput. So when you said they should make them maybe trim a little bit hair off, I said, well, see, I told you. It's powerful stuff. Now, you are putting this into their heads, and you're going to multiple places until you get your dose that you want. And then off they go, and you're monitoring them and checking up on them. Some people do manage to get a story in, though. You do get to hear a couple of those, I had a bad dream or I had a bad experience. So that's good, too, because, you're there for those people, too, right? A couple of them got to talk to you, which is good.
Yes, absolutely.
Now, when you said you think that your contribution is in your treatment protocols and everything is going to be that, like, a lot is going to be good too. You're going to have lasting effect is what we kind of, the trickle in, the rumor, the overall thing is, if I do high power, I'm going to have, long-term changes, So that's what you're finding too, that these are they stick, they're a little more permanent, right?
Absolutely. It's nice to get a temporary change. It really gives you the power of photobiomodulation. And I'll be honest, not all my patients have had what I can, for sure, permanent treatment, permanent results, and I consider that a failure of the treatment. If you only have temporary, both pain and brain, pain is you have chronic conditions, it's a little different, but if you only have temporary results, then it is a treatment failure, in my opinion. That really has not achieved the patient's goal. They come in expecting, you're going to change me so I don't live this life of being afraid of life.
Absolutely. Now, I don't think that you're too far off, because you're in Southern California, where probably within 5 miles of your offices, you've got 10 different places that are putting something on people's heads. So they can have transcranial magnetic and ultrasound and blah, 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 but everything that you can think of. And they really don't know what that's doing either, do they?
I think that, as far as the head goes, anybody who tells you they know what's going on inside of the brain is lying.
Well, you saw that my little galaxy, on my banner there is the galaxy and the neurons, so, you're not
exactly
too far off there. And so, yeah, it's probably, a great therapeutic benefit to be able to see numbers like that being put out on people, and try to have a good idea, give that out to the community, because people are using very low doses, things like that, and people are using, like you're Thor the hammer, you're Thor the boom. Give it to them. And do you think that you're going to have be able to get this to the home? Do you think you're going to be able to get this so that people can, self-administer this amount of juice?
So I think that there's some people out there who are developing head units. And I think that over time, it could be that 8 hours of sort of a head unit equals, for a week, equals my dose. I think that's option one. Option two is, yes, I would like to develop sort of a backpack unit that a medic in the field could use. And one of the big problems, and it's actually, I didn't realize this about PTSD until I got into the field. But for veterans, a lot of veterans do, no matter what you do, do not want to, or might not live near a clinic, but they don't want to come into the VA. I don't work with the VA, but they don't like the VA. The VA has failed them. Even if they live near one, they don't want to go to one. If they do live near one, they definitely don't want to go to one. And then there's actually the civilian side. I think the number of civilians with PTSD might be 5 times higher than vets. And most of those, the number one group there are victims of sexual trauma. It's another, I'll be honest, it's another arena that when you're giving anesthesia, you don't think about sexual trauma or PTSD. But once I started speaking to some of these patients, they live a life beyond misery. A lot of my photobiomodulation brain patients are essentially homebound and afraid to go outside, afraid to speak or talk or do anything. They have been so victimized and abused. And you could have the nicest clinic in the world, staffed by the nicest people in the world, and it is too big of a bridge for them to jump over, or too big of a river for them to jump over. And so the people who need the therapy the most are the hardest to get out. So I think in the end, we have to aim for something that takes the photobiomodulation to the patient.
And if I could just get a little bit ethereal for a second. Like you guys are the anesthesists really are working with consciousness in one way. You're making you unconscious. And you know what I mean? You understand that they come back. Sometimes they don't come back all the way, right? They can have that, everything decouples. They were talking about the microtubules, and Liebert was talking about that after anesthesia. And then they have cognitive impairment when they come back for whatever reason, right? So they think that this is just a consciousness thing. And here you are taking care of emotional trauma with high-powered laser. Do you have any idea how light energy is interacting with the emotional aspects of people? Do you have any perception on that perspective?
I don't know how it's interacting, but I can tell you that the effect that it had on my patients, has been unbelievably powerful. It changed them and it changed me. Mm-hmm. And all you have to do is laser 1 or 2 or 3 people at most. If it's the first one doesn't do anything, laser 1 or 2 more. And you will, even if you're an anesthesiologist and you don't want to talk to people, you will notice emotional changes that you realize are not random. They could not possibly. And it'd be like a meteor hitting the moon, not even the Earth. That's how likely these changes would have to be.
I'm following you, and I think that you're changing these people's lives. Just to see those graphs go down and the changes in the data that you're doing. You did a great job. You're doing a great job. Keep it up. I'm sure we're going to have a lot of discussion and people wanting to get a handle on these different protocols. Thanks a bunch, Doc, for your time. Thanks for participating.
Joe, thank you. Bye-bye.